Hello, everyone. Just putting Instagram as always first. There's always a little bit of time here. Done. Okay, so thank you so much, everyone, for tuning in. Dr. Isabelle Amigues, your friendly rheumatologist, and this is another episode of Rheumatology 101. Such a pleasure to be with you. And today is the second part of pseudogout. So we talked last time about what is pseudogout, and today we're going to talk about how we diagnose pseudogout. And then we may actually go into the treatment of pseudogout because both how we treat and how we diagnose pseudogout is actually not super long. So I think we can probably combine them. So remember, we talked about the fact that pseudogout is a crystal inflammatory arthritis, and that basically it looks a lot like gout. We talked about the fact that when you look at what is the cause of pseudogout, we find that it's calcium pyrophosphate deposits, so the crystals of calcium pyrophosphate, CPP, D for deposit, right, and disease. And so how do we diagnose it? So remember, an inflammatory arthritis, usually worse in the morning, usually worse when you're not doing anything. And really, for pseudogout and gout, super swollen joint, very painful, severe, like to the point that just a touch is extremely painful. And so we basically, when we are suspecting pseudogout, usually it's because you have a very swollen knee, very painful, very swollen knee, or you have some like something that looks like gout. So maybe it's the ankle that are swollen. Maybe you have a first toe that's swollen and painful, and you have this pain that shoots up, is severe, and then you have moments where you have nothing. And that's pretty typical of crystal, because if we're talking about rheumatoid arthritis, which is another type of inflammatory arthritis, usually it's more like chronic, and it just like you have flares, but it never comes down to zero. So how do we diagnose it? Well, the first thing is to listen to patients, right? What are the symptoms? When do you have the pain? What other problems do you have? So for example, for pseudogout, we saw last time that if you have kidney disease, you have more chance to have high calcium level of yourself because you have hyperpara. It's what we call secondary hyperparathyroidism. So little gland on top of the thyroid that manage the calcium balance in your body. And so right, knowing what type of patients we have is going to help us figure out if they are at risk for this, right? And then you go into, okay, well, how does it present? Is it just one knee? Is it two knees? Is it also the hands? Is it symmetrical? Is it asymmetrical? And so on. That actually is not enough to tell us that this is crystal arthropathy and that this is pseudogout. And so usually the main diagnosis, like how we call the gold standard for diagnosis, is to actually look at the synovial fluid. So remember, I was saying that all of your joints have a little pocket of fluid. Absolutely normal. This is how you have lubrication. And then when it gets inflamed, that pocket of fluid gets distended, and gets swollen, inflamed. And you can actually put a needle in that pocket of fluid and you can retrieve the synovial fluid. Usually, it's going to be very inflammatory. And usually, what you're going to find is that you're going to actually find crystal of CPPD. And so you can look at the microscope and you're going to find those crystals, and then you have your diagnosis. There are other ways that you can do that you can look for CPPD, is actually to do an X-ray of several joints. So you can do the X-rays of the painful joint, but you can also do the X-rays of your pubic bone, because there can be, and so I'm going to tell you all the X-rays we do. We do X-rays of the wrist, we do X-rays of the knees, and we do X-rays of the pubic bone anytime we're thinking of pseudogout. And why? Because you can find crystal deposition, and because it's calcium, it's going to pick up the radiographic. So basically, it's going to be opaque on any sort of X-rays. And so we're going to find that there is this second line, as if you had a double joint. And so that's super typical of what we call chondrocalcinosis. That's what we call it on the X-ray. And that's usually caused by pseudogout. So you can have chondrocalcinosis and not have pseudogout. That's when you have no pain, no joint swelling, nothing. But if you do have joint pain, joint swelling, then if you have chondrocalcinosis on X-ray, then you have pseudogout. Okay, so it's fairly straightforward. The gold standard synovial fluid analysis to check for calcium crystal. And then you can also do the X-rays to look for this deposition. Now, we also do ultrasound. I love to do ultrasound, and you can actually see the chondrocalcinosis also when you're taking your probe and looking at the joint. You can see what we call a double contour sign, because instead of having just one contour for the cartilage of the joint, you have a double contour, you have a second one. And so that can actually help also make a diagnosis. In general, I would say the vast majority of time, you want to do arthrocentesis. So you want to put a needle, get some fluid out, and look at it under the microscope. That's the best way. Now, treatment-wise. So you've made a diagnosis of pseudogout, and you are ready to treat. I would say, so this is important, sometimes people have seronegative, so that means that they have rheumatoid factor negative, CCP negative. So they have seronegative rheumatoid arthritis. And those patients do not respond to treatment for rheumatoid arthritis. Well, for those patients, I highly recommend you look for pseudogout, because very often you will find that they actually do have pseudogout, and it was never seronegative rheumatoid arthritis. So always be very open-minded when it's seronegative rheumatoid arthritis. If you have high rheumatoid factor, high CCP, then you have rheumatoid arthritis. But if you do not, and you do not have erosion that are typical for rheumatoid arthritis on X-rays, then be open-minded about the fact that this may be crystal arthropathy, especially if you do not respond to the usual treatment for rheumatoid arthritis. Now, let's talk about the treatment, right? So I said, how do we diagnose? Let's also talk about treatment. How do we treat pseudogout? Well, the first thing is, remember, I was mentioning the fact that there are some secondary causes for pseudogout. So we mentioned hyperparathyroidism. We mentioned issues with the magnesium. We mentioned iron issues. So you treat those, right? If you have a cause, go to the root cause, you treat those. And then we're going to need to treat for the inflammatory component of this condition. I love NSAID, but I also hate it. NSAID, non-steroidal anti-inflammatory drugs. Those drugs are great. They really help with inflammation. The issue is that if you have a patient with kidney disease, you are going to make it worse. And so you do not want that. So we have a drug that we use for both gout and pseudogout called colchicine. That's actually pretty safe. And we can also give that for patients who have pseudogout. It's crystal arthropathy. It probably should work. And then what's really interesting is to go, if that's not enough, if the NSAID was not enough, you can do a little bit of prednisone. The problem is that you want to take care of it long-term, and prednisone long-term is a no-no. Too many complications. So you do not want to do that. So if you have just one joint that's swollen, that's really just the only joint that's bothering, I agree, give an injection, we're good, right? Injection of steroid, you can be good for 6 months, that's great. You can have 3 injections per year, that's excellent. But if you have more than just one joint that's swollen, painful, and that's bothering you, then you try the NSAID, as long as it's safe for you. You can try the colchicine also. And then you have to go to the next step. And one of the next step is to give methotrexate. And then you're going to tell me, hold on, Dr. Amigues, you told me that methotrexate was for patients with rheumatoid arthritis, and you just told me that Sometimes it doesn't work for patients with, chondrocalcinosis and pseudogout. And I will tell you that's the art of doing rheumatology. It's not obvious. And so, yes, we try methotrexate because we do not want you to be on prednisone steroid. And so we try methotrexate, and sometimes it does work. And so that's worth trying. Very often, I find that it doesn't really work. And so my goal is to get my patients to full remission by really tackling what is the underlying cause of pseudogout. And then by getting my patients to full remission and trying to get rid of the inflammation that's in the joints of a patient with pseudogout. I have used anakinra, which is a biologic and is an anti-IL-1 in some patients with good benefit, but there's not a lot of studies on that. Usually, we are able to take care of pseudogout with colchicine. Usually, really, I've seen many patients, but the way we do it is that it's once a day. So usually, and then when that doesn't work, we try the methotrexate. Sometimes it does work. And then when that doesn't work, we have to sometimes try other stuff. So it's 11 minutes. I'm going to look at the comments. Hi, Keith, Rock Dog, such a pleasure to see you every week. It's always great. Hi, Lisa. Hi, Oksana, and hi, Nicole. And if you are looking at the episode letter, you can, put hashtag replay. This is an interesting topic, the pseudogout, because it's not really talked about a lot because we actually don't have that many treatments, but you have to really make the diagnosis so that you can properly treat it. And also you can really potentially can help by finding the secondary causes of pseudogout. And, one of the things that we were mentioning was this iron profile. So you can check an iron and the iron profile. And I have made diagnosis of something called hemochromatosis, which is basically an issue with too much iron. And it's a genetic issue that's too much iron on your body, and it can cause that. And so you can actually have complications from the hemochromatosis. And thanks to the chondrocalcinosis, the pseudogout, we were able to find that diagnosis. And by finding that diagnosis, then the really cool thing is that we were able to treat it and prevent further complication from hemochromatosis. So there's always something good to learn from our conditions. And so that's what I want to leave you with. I forgot to tell a story this time, so next time, but that's okay. So at least we did both diagnostic and treatment. And next week, we'll have a new topic. And I hope to see you. And until then, I wish you a really, really good week. Take care, everyone. Bye-bye.